Hello, I'm Jack Keyes from the University of Cincinnati, and I'll be talking about models of adherence. The system adherence model that we have developed has come partially from the literature, interviews that we have had with providers, and existing models that are already available. As you can see by looking at the model, there are two major parts to this model, represented by triangles. One on the left includes the patient, healthcare providers, and other providers. The one on the right includes adherence, external factors, and health outcomes. I'd like to talk for a minute about the triangle on the left, the patient, healthcare providers, and other providers. This part of the triangle really sets up the potential for adherence or non-adherence before the patient actually leaves the office or as the patient is given the prescription or treatment plan. Patients interacting with their physicians and other healthcare providers receive a message that describes the overall prescription or treatment plan. As we know from the literature, that communication between physicians and other healthcare providers and patients is very seldom perfect. It becomes more complicated when a patient is interacting with a number of providers who may intentionally or unintentionally give mixed messages or conflicting messages that make it difficult for the patient to understand what the treatment regimen or prescription is. It's important, looking at that part of the triangle, that providers, where there are more than one, are giving the patient a single and consistent message, and that there is some follow-up by the healthcare providers to make sure as much as possible that the patient is hearing the message that's being given. So moving from left to right, when the patient has a message, they are in a position where they can adhere or not adhere to the prescription or treatment regimen that is prescribed. The patient's intention or motivation to adhere is an important factor here. But remember that what the patient believes they are hearing or believes the treatment regimen to be can be equally important. Patients occasionally will leave a treatment situation with what they believe to be the treatment regimen or a partial regimen, and they intend or are motivated to be adherent, but they may not have gotten the entire message, or they may have gotten mixed messages. Obviously, if a patient is not motivated or does not intend to comply, it becomes a serious problem for adherence. I'd like to take a moment to look at the right side of this model and the triangle that includes adherence, health outcomes, and external factors. There are a lot of things that we know as external factors that impact patient adherence. Things like health beliefs or literacy, the financial situation of the patient, stress, psychological conditions, and a variety of other variables that are outside of the typical treatment model that influence the patient's ability to be adherent. But I'd like to take a look at the line that connects adherence to health outcomes. This is a line that practitioners assume is there and is very strong. If a patient is adherent, there will be certain health outcomes. Occasionally, treatment regimen, for whatever reason, may not be perfect, or the health outcomes may not be what the healthcare provider would like to see. As an example, a patient seeing a practitioner for hypertension is given a prescription and asked to come back in 3 months. When they return to the physician's office, their blood pressure has not been reduced adequately, and the physician is in a situation where they can assume that the treatment regimen prescribed was inadequate to lower the patient's blood pressure, or they can look more closely at whether or not the patient was adherent to the treatment regimen that was given. If they assume that the patient is adherent, the physician may prescribe a stronger or different medication. If in fact, however, the patient wasn't adherent, but decides after this second visit where their condition is not improved that they will be adherent, we have a situation where the patient is now over-medicated or on an inappropriate medication. So this brings up the issue of what we measure as a surrogate for patient adherence. You can measure it directly and then look at the relationship between adherence and health outcomes, or we can look at health outcomes directly and make an assumption that the patient was adherent. So these are important things to consider as we move forward and looking at the overall issues of patient adherence. As a consequence of what we found and the development of this model, we developed a simple model for clinicians referred to as the Ask-Adapt model. The Ask-Adapt model really looks at both sides of the treatment model or the adherence model described on the previous slide. What we're talking about is the need to engage the patient to determine on the left side of the model that we saw whether or not they are capable of being adherent or whether or not they understand the treatment regimen that is being prescribed. On the right side of the model, the ask part of the equation is to assess whether or not the patient was adherent using health outcomes, adherence directly, and some of the external factors as important things to ask the patient about. The second part of the Ask-Adapt cycle, the ADAPT model, requires the clinician to consider some of the factors that may make the patient a risk for non-adherence or indicate to the clinician that the patient is not adherent, and gives the clinician some data that will help them make some modifications in how they are working with the patient to, in this case, adapt to the patient or the conditions under which the patient may or may not be adherent to the treatment regimen. So, for example, looking at the left side of the model, we can identify patient factors that may contribute to non-adherence, things like cognitive impairment or just a belief model that does not accommodate the treatment regimen that the physician has prescribed. This may also identify medication factors that can contribute to non-adherence. Patients that have difficulty adhering to a complex regimen or do not want to be subject to certain side effects. It also, the ask part of the equation here would also suggest that it's important to assess whether or not the patient really understands not only what the regimen is, but also the value and effect of adherence and of non-adherence. Part of the asking equation for the left side of the model also includes whether or not the patient is capable of adhering to directions and looking at therapies or medications that may also be complicating a patient's ability to adhere. So these are all part of the left side of the equation in terms of ask. The adapting part of this model would suggest that physicians can take some very positive steps to improve adherence by adapting their optimal prescription or their optimal treatment regimen in order to improve adherence and thereby improve the care of the patient. Part of the adapting suggestions here would include simpler instructions on a regimen, customizing the regimen in a way that accommodates some of the patient's needs or wishes. In some situations, either with pediatric patients or elderly patients, patients that have impairments or situations that make it very difficult for them to adhere alone, engaging the family or other caregivers is an important thing to consider. Enlisting other healthcare providers, patient educators. We certainly see this in the diabetes care model, but also looking at support staff such as dietitians or physical therapists can be very helpful. Also identifying mechanisms that will address some of the external factors that we know impact adherence, identifying low-cost medications, choosing to prescribe medications that are taken, say, once a day rather than multiple times a day, providing the patients with literature at a level that the patient can understand, and also to talk to the patient and reinforce the importance of the desirable behavior and talking to the patient about the consequences of non-adherence. So these are part of a strategy that physicians can use to engage the patient, asking them what's going on, trying to determine factors that put them at risk for non-adherence, or identify parts of a treatment regimen where they cannot be adherent, and also adapting a treatment plan to some of the limitations or preferences that the patient has in order to better care for the patient or ultimately provide a better health outcome for the patient. So the Ask Adapt strategy is an iterative strategy. It needs to take place as part of the overall engagement of the patient, both prior to discussing a treatment regimen with the patient and following up with the patient after you have engaged the patient with that treatment model to assess any risks or impact of their behavior on adherence. The few extra minutes that this engagement may require from a practitioner certainly provides them with a wealth of information and good strategies for working with the patient to improve their overall adherence and make treating the patient much easier for both the clinician and the patient.